Let's review trauma alerts. First, what sets trauma centers apart from other hospitals? Trauma centers are specifically equipped and staffed 24/7 with in house trauma surgeons, anesthesiologists, and consultants whose specialties are related to trauma, like neurosurgery, orthopedic surgery, and critical care medicine. Trauma centers have immediate access to the OR, ICU, radiology, and blood bank. There is a robust body of research out there that shows that patients who are treated at trauma centers had significantly better physical function and independence 1 year after their trauma when compared to patients who were seen at non trauma centers. This reinforces the fact that trauma centers don't just focus on survival, they're designed to return people to pre trauma level of function as much as possible. In trauma, time is tissue. Therefore, delays in hemorrhage control, airway management, or decompression of a brain bleed can mean the difference between life and death. Trauma centers are designed for speed and readiness with their 24/7 availability of ORs and surgical subspecialties. This access is particularly vital in high-risk conditions like internal bleeding, traumatic brain injury, and open fractures. It's not just about the initial resuscitation. The ongoing specialized inpatient care also makes a difference. The evidence also shows that trauma centers reduce complications. Through established protocols, trauma-specific nursing, and continuous quality improvement programs, trauma centers reduce the risk of missed injuries, infections, and sepsis. Trauma centers aren't just better because they have more equipment, they're better because they have the systems, staff, and expertise to make complex trauma care coordinated, timely, and recovery-focused. How do hospitals and the healthcare system as a whole figure out which patients should go to a trauma center? There's the injury severity score, which you might have heard of. This is a scoring system that they used in the hospital, but let's reframe it so that we can see what the hospitals look for to measure how bad trauma patients are. They divide the body up into 6 systems, take the worst injury from each system, and rate it 0 through 6, with 6 being an unsurvivable injury. The injury severity score uses the 3 highest scores, or in other words, the 3 most severely injured regions. The score is calculated by taking the sum of the square of the 3 highest numbers and can range between 0 and 75. A score of 15 or greater is indicative of major trauma. As an example, if a polytrauma patient were to have a serious head injury, a severe chest injury, and a moderate leg injury, their score would be 29, consistent with major trauma. Are you expected to do this score in the field? Absolutely not. But you can have a pretty good sense of it by recognizing certain factors that, once you think about it, aren't that surprising, such as a major mechanism of injury, like a high-speed rollover MVC, a GCS less than 8, or unstable vital signs like tachycardia or hypotension. Kids in general are smaller, and so the force from an MVC or fall involves more of their body, resulting in an overall bigger impact. Their heads are also proportionally bigger, and their organs are less protected by thinner chest walls and less fat tissue. On the other hand, our older patients tend to be frailer and have underlying comorbidities, especially the use of blood thinners. You all know to ask for and document these details, which are more useful than just some checklist. You have the clinical judgment, and you should use it. The most powerful predictor of injuries is the mechanism. High-speed MVCs, falls from at least 16 feet high, penetrating injuries, and crush injuries. Don't wait to see the vital signs start decompensating. If the mechanism is bad, use your paramedic discretion to activate the trauma alert. What other factors do you need to keep in mind? A systolic blood pressure less than 90 in the setting of trauma is considered shock until proven otherwise. Tachycardia, especially if over 120, means something is imminent. A GCS of 8 or less requires a trauma center, period. And of course, a head injury with blood thinners might be an impending head bleed waiting to reach critical mass. Why do blood thinners like Eliquis, Xarelto, or Coumadin matter? These medications inhibit the body's natural ability to form blood clots, and so a seemingly minor head injury could be a high risk factor for intracranial hemorrhage. Multiple research articles have proven the concern for an occult or delayed head bleed, which typically happens within 24 hours of head trauma. Many researchers have looked into the risk of blood thinners and head injuries. A study published in 2006 showed patients on warfarin had a 6-fold increase in mortality risk. What about drugs like clopidogrel, more commonly referred to by its brand name Plavix? You might hear some people say that these medications don't count as blood thinners, and those people would be technically correct. They're antiplatelet agents, which have a different mechanism of action from anticoagulants, but with the same end effect of inhibiting the body's natural clotting function. What have researchers found about patients with head injury and these medications? Based on the science, we still haven't reached a universal consensus about how significant a risk factor these medications are as compared to your typical blood thinners. That being said, their effects can't be completely ignored. A large review of over 14,000 patients showed a risk of over 50% of intracranial bleeding after a mild head injury. If you add aspirin to the mix, there's even greater risk. Clinically, that means these medications can be all the difference between mechanisms like these, ending with either nothing or a very serious something. All that being said, what does this mean for our management of patients in the field? It means that we would like you to take everything we just discussed into your judgment when triaging the patient. Our job is not to perfectly diagnose every patient. It's to calculate their risk of life-threatening injury or disease based on what we see and what we know as EMS clinicians. As a whole, we would like the incidence of under-triaging patients to be less than 5%. On the other hand, we accept 25 to 35% over-triage. In other words, we are much more okay with having patients who end up with no serious injuries being taken to a trauma center over patients with serious injuries taken to a lower level or non-trauma hospital. Why such a difference between the two standards? Because over-triaging is a systems issue, while under-triaging is a patient safety issue. To address under-triaged cases, many EMS systems have a trauma gray in their protocols. The idea was straightforward. If a patient is 65 years or older, on blood thinners, and has a head injury, the paramedic automatically activates a lower-tier trauma alert. The intention behind this rule was good. Older adults are frequently under-triaged, and anticoagulation increases the risk of intracranial hemorrhage. The goal is to prevent missing serious injuries in this population. However, over time, we've learned that these kinds of all-encompassing automatic rules have several major downsides. Firstly, they contribute to significant over-triage. If every single geriatric patient who fell triggered the activation of a whole team of surgeons, nurses, ER docs, RTs, and radiology techs, these limited resources are unnecessarily diverted from other patients and contributes to crowding in the ER. Second, overly rigid protocols can reduce clinical judgment in the field. Paramedics are trained to integrate mechanism, physical exam, vital signs, and patient history. When a protocol automatically mandates an activation based on only a few criteria, it removes the opportunity for providers to apply that clinical reasoning. Lastly, very broad activation criteria can lead to what some trauma systems describe as activation fatigue. When trauma teams respond to large numbers of low acuity alerts, it can dilute the urgency and focus that should exist when a truly critical injured patient arrives. Because of these issues, National Trauma Triage Guidance emphasizes balancing over-triage and under-triage while also recognizing EMS provider judgment as an important part of the triage decision. So rather than relying on a blanket category like trauma gray, we want you to use your judgment to make the right calls by considering the mechanism, physiology, injuries, and patient risk factors. And that's all we have for this episode. This is a production of Redfield Medical Direction. This episode was produced by me, Lin Win. The theme music is by Infraction. As always, don't hesitate to reach out if you have any questions. See you next time.